टाइम क्या हो रहा है? ये है। कहाँ है? Yeah.
डॉक्टर ब्रजेश, एक
Yes,
मिनट
sir.
जरा.
Good evening.
गुड इवनिंग. आप जरा एक मिनट इसको रोक के आपका फेस दिखा दें तो आई वुड लाइक टू इंट्रोड्यूस यू टू माय पार्टिसिपेंट्स.
Yeah, sure. इसको स्टॉप शेयरिंग करो, वीडियो ऑन करो इसमें.
आपका वीडियो ऑन कर दो, फिर हम पिन कर लेंगे.
Yeah. Can you see me, sir?
आई कैन सी यू, बट ये आपने इसको स्टॉप शेयर नहीं किया है अभी तक.
अच्छा, मैं इसको स्टॉप शेयर कर दूं.
हाँ. Yes, I can see you now. So, dear participants, I welcome Dr. Brajesh Kumar Kunwar on your behalf, the very dear friend and associate of over a decade. From the time he was at Seven Hills, he's been treating my patients and we have been communicating. Now he's at Vashi. So, as luck would have it, a distant relation of mine from Ulhasnagar came to me and saying that he has edema. He had edema feet and he was dyspneic. So when we did his 2D echo, it had a ejection fraction of 20%. I asked him, "You had COVID?" He said no. So we put him on treatment of failure and we waited for some time. Then in Ulhasnagar, he went to cardiologist who gave him digoxin, which I was not very happy with. So I sent him to Dr. Brajesh. And Dr. Brajesh saw him and he said, "This looks like post-COVID myocarditis. He must have had a silent attack." And just to confirm, we also did a angiography that day, which showed very small vessel disease, nothing to cause that kind of inflammation. So it was proven to be a post-viral myocarditis with patient never having had fever in last 6 months or even 1 year. So absolutely silent cases also are likely to get complications. And that's spur of the moment I asked Dr. Brajesh, "Will you take a lecture for us?" And he said graciously agreed because his CME calendar is very, very busy. So I am delighted to present to you Dr. Brajesh Kumar, a dear friend. Dr. Brajesh, please go ahead.
Yeah, thank you very much. We will straightway go to the topic. Can you see my
Yeah,
slides?
we can see the screen, sir.
Okay.
Please make it slideshow.
Yeah, I will. Okay.
Yeah, perfect. We will take questions in the end. Please start, sir.
Yeah, it's somehow the slide is not moving. Okay. So as we know that the biggest killer right now, if you talk about all the diseases which happens in the world, is of course the coronary artery disease. That means the heart problems. So 1 in 4 deaths in India happens because of heart problems, and we all know that we are going through a pandemic of COVID infections, but this epidemic of coronary artery disease has been there for long. And to be very frank, the second organ to get affected after lungs in COVID infection is the heart. So heart and most of the cause of death in COVID patients are usually related to heart problems. So if you see in ICUs, the people who die of COVID, the end event or the event which caused death is usually the involvement of heart. So what creates more of a panic is, the lack of facilities. Now, once somebody is diagnosed with a COVID, his admissions becomes an issues, his availability of beds becomes an issues. Not many hospitals are allowing cardiac patients with COVID positive. Not many cardiologists are ready to come and see the patients. So these all issues were there. We were when this pandemic started, we were lacking facilities to deal with these patients. So that created more of a havoc. The patients, the mortality were more. The patients also were for failing to recognize their symptoms. So that leads to delayed in presentation, delayed in treatment. So those were the issues which creates a problem. Now, if you ask me what is exactly COVID does to the heart, I mean, it has a direct effect and it has got indirect effect. So direct effect means it affects the clotting system of the blood. So if you in suppose you cut your hand with a blade, you will find the bleeding comes, and after some time there is a natural phenomena by which this bleeding stops. That bleeding stops because of the activation of clotting factors. Now what happens in this COVID infection is, and this is directly related to the severity of COVID infection. More severe the patients, more will be the blood bleeding clotting chances. So once this patient gets affected with the COVID, their clotting mechanism increases. So these patients, they develop, increased chances of clotting, and that this clotting can happen anywhere. It can happen in heart vessels leading to heart attacks. It can happen in the lung vessels leading to pulmonary embolism. It can happen into your limbs causing acute limb ischemia. So these problems can happen because of clotting mechanism. Second thing is, these virus can directly infect the heart muscles also. Now if it directly infect the heart muscles, rather than affecting the blood supply of the heart muscles get damaged. They weakens up. Sometimes this heart muscles damage is also immune mediated. They incite an immune mechanism which leads to the damage to the heart. So we very often see a patients who have been treated for COVID infections in ICUs, and when they get discharged, they do come back to us with breathing difficulty, and we found that these patients have heart pumping power being reduced. And the most common cause of this heart pumping power reduction is basically the myocarditis. That is, the virus has infected the heart muscles, or indirectly it has led to the damage of the heart muscles. Third thing is the electrical system. Now we very often see patients coming to us with arrhythmias. They come with either a heart rate being very fast or the heart rate being very slow. So there is an electrical system of the heart. Now that electrical system, the work of electrical system is to make the heart pumps at a constant rate. That rate may be between 60 to 100, but this virus can infect this electrical system of the heart, and that can lead to either heart rate being very slow or can lead to heart rate being very fast. We call it as an arrhythmias. So these are the three mechanisms by which this COVID can affect the heart. Now this can happen during the COVID infection, active COVID infection. This can happen post COVID. Patient can come after 1 month of discharge, and this can also happen in a patient who is not recognized, or whose RT-PCR is negative, or whose rapid antigen test is negative, because we are finding so many patients with false negative, false positive results. So this can happen in these three patients. In fact, sometimes the only presentation of COVID infection is a clotting phenomena. I have seen the patients presented to me with heart attack, and only problem was there was a formation of clot in the heart vessels. So that led to the heart attack, and when we investigated, we found that this patient has a COVID positivity. The indirect effect about COVID is, see, some people who are already on heart medicines, they are taking already treatment of heart diseases, and once this COVID came and the lockdown started, not many people came out and could get their medicines easily available. In fact, some people could not follow up with their doctors. The online consultations were difficult to get, so those patients deteriorate as they were not properly taken care of. And important thing, as we all know, that stress is one of the very major factors causing heart problems. So the stress during last 1.5 years has been immense. It is the stress of the business. It is the stress of losing a job. It's a stress of getting a COVID. It's stress of relatives dying of of COVID. So all those things has affected the COVID mortality or deaths related to COVID. So what are the risk factors? If you see, the risk which leads to COVID affecting the heart being older age, then the older people get more affected. Their organs are already working at a borderline. So once they get affected, these organs can easily get involved with COVID. Then comorbidities like other conditions like lung disorders, renal diseases, they have other systemic inflammations. As I said, COVID can induce coagulation abnormalities that can lead to complications. Then other patients immobile, they are not moving around, then clots can form. So this can lead to myocardial injuries, it can lead to heart attacks, it can lead to heart failures, it can lead to arrhythmias, which we call as electrical problems of the heart, and it can also lead to formation of clots in the body. So what is important is to identify your symptoms very correctly. Now, as we know that symptoms of COVID infections, they often look similar to cardiac problems. The patients of COVID can have symptoms of breathlessness, can have symptoms of breathlessness. So they can have cough. So what is important is to understand what is the difference. For example, if a patient of COVID starts developing swelling of the feet, if the patient start feeling that he is getting more quickly weight, if the patients of COVID starts feeling that the cough is more in the night when he lie down, if a patient of COVID start feeling that the tiredness is more now, if a patient of COVID start feeling a typical type of chest heaviness, please make sure you get your heart checked, because these symptoms can be related to an associated cardiac problem. Cough in COVID is usually not nocturnal, but suppose you lie down in the bed at 12 o'clock and you get up in the night at 2 o'clock with a breathlessness and cough, that is probably suggesting that the patient has an underlying cardiac issues as well. His heart may not be pumping well. So that is one thing. Similarly, COVID cannot cause swelling of the leg. If somebody is developing a swelling or puffiness of the face, make sure you check your cardiac issues, because the low heart pumping power can be responsible for your symptoms. So certain symptoms, for another thing is the giddiness. If the patient starts complaining of recurrent episodes of syncope, or we call it as a blackouts, then again you need to check with your cardiologist to see what is happening. Is the heart rate being proper? Is the BP being proper? Is the heart pumping power being normal? So as we know, the first effect what the COVID causes to the heart is, of course, the heart attack. So the patient can have chest pain. Chest pain can be associated with nausea, vomiting. Patient can have an anxiety. Patient can have a giddiness and sweating. If a COVID patient develop chest pain associated with all these things, please make sure you immediately get your ECG done and rule out heart attacks. Then the other problem which a COVID patient can have is a myocarditis. Myocarditis means it is the infection or the inflammation of the heart muscles. That means heart is either directly damaged, as I said, directly damaged, or it is indirectly damaged through immune mediated response. So in these cases, as sir rightly mentioned, the patient he sent, we did an echocardiogram, we did an ECG, and we came to know that the tiredness or the breathlessness what he's having is not because of lungs, it is because of the cardiac problem. Some other important blood tests are also there which can differentiate breathlessness because of lung issue or breathlessness because of heart issue. One of the tests is NT-proBNP. Now this is a blood test. If a patient of COVID does this test and NT-proBNP is found to be very high, it usually suggests that the patient breathlessness is also contributed by a cardiac problem. So it is important that that patient need to be checked for cardiac issues. So right diagnosis and right treatment is very, very important. Most importantly, the patient has to undergo right diagnosis so that the right treatment can be given. Now, as I said, heart rhythm abnormalities, this can be very simple heart rhythm abnormalities. There are certain rhythms where the patients are absolutely stable. We do see a patients with this rhythm known as atrial fibrillation, atrial ectopics. Now, these patients, they may come walking to the OPD either during COVID or post-COVID. Now, these rhythms are usually not life-threatening. But of course, if these patients come with certain life-threatening rhythms, for example, ventricular tachycardia, ventricular fibrillation, now these can create a problem to the life, and these problems are more common in ICUs, and most of the common cause of death in ICUs are these terminal heart rhythm abnormalities. The patient dies in ICU usually as an end result is this heart rhythm abnormalities. Again, in that case, it is very, very important you rightly diagnose it and you rightly get a timely ECG, and if required you treat it either with the medications, and sometimes we need to give a DC shock. So that is important. Sometimes they don't give us chance and the treatment has to be immediately placed in. So another problem is the clot formation and migration. See, as I said, this COVID can affect the clotting abnormalities. So these patients can have deep vein thrombosis. Now veins are actually pipes. Now these are pipes which takes the blood from the periphery, from the leg, hand, head, back towards the heart. So that deoxygenated blood, or a blood which is devoid of oxygen, or the blood which has already given oxygen to the tissues of the body, is now going back to the heart, and from heart it will go to the lungs for oxygenation, and then again it will get circulated. So that vein, which major work of these veins are to take the blood back into the heart, they get clots. Now, once they get clot, there will be swelling of the leg. The leg may change its color. And what is important is if this clot which develops in the veins, they get migrated towards the heart, and from heart it goes into the pipe which connects heart into lungs. We call it as a pulmonary embolism. So deep vein thrombosis, that is vein getting clotted, is not a dangerous situation, may not be life-threatening condition. Patient do come to us with swelling in the leg, but once this clot gets migrated into the heart and lung channel, we call it as a pulmonary artery, and it causes a choking of that artery. That situation is known as pulmonary embolism. And believe me, that pulmonary embolism has death or mortality more than the heart attack. So that is the worrying thing in COVID, that we do a lot of patients who come to us with pulmonary embolism, we come to us with DVC. So arterial occlusion or blockade can also happen. Arteries are the pipe which supplies blood to the different tissues. Just a minute. So arteries, if they get clogged, as I said, veins work is to take away the dirty blood back into the heart, and lungs. The arteries' role is to take the fresh blood into the tissues. That means they supply food and nutrition and oxygen to the limb. If they get clotted, we often see a COVID patients coming to us with arteries being clogged, arteries being blocked. Now, if they come to us with this, what is the presentation is they will have severe limb pain, they will have pain in the artery, pain in the leg, and most of the time it requires an urgent intervention. Either you treat it with an injections which are clot busters, or you take them for an angioplasty. So this is one patient which you can see a deep vein thrombosis. See the color difference between the two legs. The limb which is up is more, you know, reddish bluish, and the limb which is normal is more of a whitish. Now this limb is congested with a deoxygenated blood which is devoid of oxygen, because this blood is supposed to go back into the heart, and from heart it has to go back to the lungs for oxygenation. So this blood is clotted, their supply back to the heart is stopped, so this blood is getting accumulated here. That is why the color of this limb is blue color. It is a dense blue. That is the reason why this patient has got a pain and swelling. Similarly, when the arteries gets occluded, you might have seen we checking your pulse rate. So once you get an arterial occlusion, arterial obstruction, you see that the limb, the heart becomes white in color. You know that the hand will become pale. The movement of the hand will cause pain, and you will not be able to palpate the pulse, and there will be pain. And over a period of time, that hand can get paralysis, or it can develop painful sensation of the hand. We call it as a paresthesia. So both these things can happen. So if you are recovering, or if some of your relative is recovering from COVID, if you get a scenario where a limb is often congested, it's swelling up, it's changing its color, or if the limb has become, or the arm or leg has become more wide, and there is no pulse and patient is developing pain, make sure you immediately consult a doctor, because this can create an issue. This can be a life-threatening situation. So what are the factors which can be looked into it to prevent all these things? See, what is very important is please make sure you are very active. If you are discharged from the COVID, you please make sure at home also you are active. Don't lie down on the bed. Just don't take complete rest. Don't sleep whole day, because activities are very, very important. In fact, patients who are discharged after, or who are treated at home quarantine, who with a mild disease, the best way to treat or to prevent their complications of COVID is, of course, a good activity. You can join yoga, you can do PT exercises, you can have, you know, aerobic exercises at home. The females can have a Zumbas at home. So all those things can be done at home to prevent, you know, if you should take too much of rest, what happens is there's a stagnation of blood, and that stagnation of blood on top of increased clotting activity of the blood can lead to formation of clot, and that clot can create issues. Most importantly, food and nutrition. We often see that if we are at home, most of the people are working at home, we end up in eating huge amount of food, and most of the food is absolutely, you know, full of lot of calories. There are a lot of junk food being used. We often stock a lot of junk food at home, thinking कि अभी lockdown हो जाएगा, make sure a lot of snacks are available at home. So that creates more of an issues. It induces obesity, so that has to be kept in mind. Relaxation is very, very important. Please stay connected to your relatives. Please make sure you call your friend. You can have a group, WhatsApp group, in which you people sing and record songs. You can start learning your new have hobbies. People can play, carom board, chess. There are multiple things by which you can relax. People have a pet animal, people have a gardening, so all those things are there so that you can relax and make sure you are connected to your relatives, your friend, because that talking to each other gives you a lot of peace of mind. You get relaxed. Make sure you follow your doctor's advice. If a doctor has started a blood thinner for you for a particular disease, make sure you continue that blood thinner. Try to contact your doctors online. Online consultation is always open. If you are not able to reach now, since even the clinics are all open, you can always have your doctor's advice. Make sure you treat properly. What is important in COVID is an early alarm. Now what we are seeing now, what we are facing a patients nowadays is patients who are coming at a very critical state. Now you need to understand that a timely treatment of COVID is 100% treatable. I have yet to see a patient who came on time to the hospital and dying in the hospital. Most of the death happens when the patient comes in a very sick situation, 80% saturation on a 15-liter oxygen. That is the time when the things goes bad. So it is important that you see yourself, assess yourself, make sure you are in contact with your local doctors, and before the things becomes out of hand, make sure you contact the hospital and get admitted. Now this is the situation can happen if you continue to eat at home without an exercise. You end up in getting a lot of weight, and believe me, obesity is one of the risk factor for all the diseases. Let it be heart problem, let it be cancer problem, lungs problem. So make sure the diet has to be proper. What I can advise you is make sure you cut down your carbohydrate means cut down your roti, chawal, dairy products and sweets. Cut down on this, increase on in salads, fruits, green vegetables, and sprouts. Make sure you take fruits like pomegranate, apple, oranges. Avoid fruits like mangoes and bananas, which contains a lot of calories, which gives you a lot of carbohydrate. So it is important that you don't stock a lot of food for snacks at your home, and the diet has to be very proper. Otherwise, you'll end up in having a lot of issues because of weight gain. If you ask me, all my patients who have come down to my clinic after a lockdown, in spite of them getting infected with the COVID, they all have come with a weight gain. And that weight gain, getting weight of, can I just attend it? हाँ अंशु मैं एक मीटिंग में हूँ, डोंट कॉल मी अगेन एंड अगेन. Yeah, I know that. Don't call me again and again. I'm in meeting. I'll come back in half an hour. Okay. So that is very important to establish what you eat and how you spend your calories. So what I was telling is, gaining a 5 kg weight is very easy, but losing a 1 kg weight, you need to put a lot of effort. So that is very important. So certain food, probably which is unhealthy, we store these foods a lot in our fridge. We often keep a lot of snacks. For us, drinking a cold drink is hardly matters. Now we sit at home, play a lot of video games. In place of video game, we can have a treadmills, we can have some walking inside the home, we can have some yogas doing at home. Avoid sweets. I always feel that if somebody gives you a gift as a sweet, eat one piece and rest of the sweet you give it to your maid, so that let her also enjoy it. Don't keep the sweets in your fridge. You eat it one piece and then make sure it is used by somebody else. That is very important. So overweight is a very important major risk factor, and most of the medical problems are concerned with that. If you ask me, diabetic, blood pressure, and certain cancers and all are associated with that. In fact, 5 kg of weight loss is equivalent almost to 10 millimeter of mercury. Many of my patients who say that the blood pressure is, once you start a medicine for blood pressure, it is for lifelong. I say it is not like that. If you lose 10 kgs of weight, if you lose 5 kgs of weight, you may end up in stopping your BP medicines, because the BP and diabetes, they directly correlates with your weight. So that is very important. Make sure you measure your BMI and keep your BMI between 18.5 to 24.9. Now, stress is very, very important. As I said, we are all going through a stress of our work, deaths in the family, loss in business. It's very, very important to stay calm and positive. The bad time, as the good time has gone, the bad time is also going to go soon. Soon, very soon, we will be free of COVID. So have positivity in your mind. Maintain, stay connected. Have your friends available all the time. Sing songs, learn some new hobbies at possible at home. So there are multiple ways, how you can relieve your stress. I've just enumerated few. You can learn some cooking methods, you can learn some new games. So take a break from your. What is happening most importantly is when we are sitting home and working, there is no breaks in between. In office you have friends, you can speak to them in between. But when you are sitting online working at home, there is no time duration. You start at 9 o'clock in the morning and that reaches 9 o'clock in the night. So what is important is in between, make sure you take a break, you get up from your seat, you walk outside, take a breather. That is very, very important to relieve your stress. So now, some of the good food or nutritious food which you can include in your daily food routine is, of course, I've kept it. I make sure that I tell my patients to have 5 almonds and 2 walnuts daily, and make sure that 2 seasonal fruits daily. That is what my advice is routinely to all my patients. Now, this type of food, ordering food through Zomato and Swiggy, has been very, very common, and I've been seeing that many of my patients are like him now, because the online delivery of food still continue to be there, and there's no work at home, and you can sit in a half pant and do office work at home with a lot of food kept nearby off camera. So that can be done. So that is one of the reasons of gaining weight. Now, there are certain medicines which is very, very important to tell you. It's a cardiac medication. There are certain medicines which you cannot afford to lose, to stop. And most importantly, all these medicines need to be continued, and we make sure that you are not run out of stock. So you can consult your doctors on phone, you can get a video consult, you can have a online prescription available, which all we people are doing. Certain drugs like blood thinners like ecosprin, clopidogrel, ticagrelol, prasugrel, acetrom, warfarin, xarelto, dabigatran, these medicines are all blood thinners. You cannot afford to stop it by your own, because either if you are taking these medications, either you have undergone an angioplasty or your valve has been replaced, and if you stop this medicine suddenly, you can end up in having issues. So then the diuretics like Lasix, Diator, Eldecton, many of the patients are already taking. Make sure you don't skip the doses of diuretics, because this can cause heart failures, that can precipitate your breathing problems. So make sure you continue these medications. Again, the BP medications, sugar medications, and certain medications like Cordron and digoxin, you cannot afford to stop these medications. Now, BP medications, most importantly, please understand that BP and diabetic medications, or BP or diabetes, they don't have a symptoms. They are slow poison. See, many a time we see in the OPD patients coming with 180, 190 BP without symptoms. So it's very, very clear that BP as such does not have symptoms. Once the blood pressure symptoms comes, that means the BP has already done a damage. It has already irreversibly done a damage. So most of the time, very high BP presentation is with a stroke or heart attack or heart failure. So make sure you don't stop your medicines, because if you stop your medications, you may not feel any change of your symptoms, but internally that high BP is causing a lot of damage. So that is very, very important. So um, so what is happening as we said, if you keep on sitting and working home, as we said, the professionals working from home are sitting and longer than usual, and also bring a lot of added stress. So even if you are doing 30 minutes per day of physical activity, it matters what you do other 23 hours. So people have an excuse that I sit and work, but I make sure that 30 minutes I exercise daily. So that is not important. What is important is, if you there is a consensus that there is a threshold of 10 hours. That means if you sit more than 10 hours a day, research shows that if you sit more than 10 hours a day, you can have cardiovascular risk really going up. So this is very, very important that you don't sit continuously for 10 hours. Make sure in between you walk around, you make sure you take a breather. That is very, very important. Certain yogas, there's certain exercises which you can go and do at home. That's very, very important. It will keep you active. Your organs will be always, working. Your lungs will be very good. Breathe, singing is a very good exercises. Yoga is of course done. Then of course certain sitting home 30 minutes workout, you can burn your calories by doing all these exercises. That's very, very important. So there are certain things which you need to follow. Make sure you check your blood pressure regularly. Make sure you have a blood sugar, your blood sugar, cholesterol, triglyceride levels. It's very, very important. Make sure you have your medicines, and that work towards a goal that keeps you occupied, such as painting, knitting, something you need to do, so that you have a passion always available. You are free from your work. You have a stress and you get involved in a good passion. You start cuddling with your pets at home. It relieves your stress. That is very, very important. Make sure your diet control has been structured since the level of physical activity is less. And it's important to stay calm and be positive and believe that this too would pass. That is very, very important. And people sitting at home often get involved in smoking and alcohol. That has to be taken care of. They should not be too much of smoking or alcohol. Please understand that smoking and alcohol is one of the form of suicide. It's if you are smoking, definitely you are trying to do a slow suicide. So it's important that you quit smoking as early as possible. So to summarize, even during this pandemic, mortality is maximum in cardiovascular disease patients, and the range of 12 to 18% compared to 1.5 to 3% in patients otherwise. So the mortality is high of cardiac patients in cardiovascular diseases. So golden rule of continuing cardiac medications, blood pressure medications, and heart failure medications, along with statins for cholesterol, has shown that the death rates in COVID is reduced if you continue these measures. During this time as well, get immediate treatment of cardiac emergencies, symptoms, and don't ignore sudden death. And as COVID related, complications during COVID and post COVID continue to grow. Make sure you are attentive, you timely recognize your symptoms, timely get an expert opinions. And if you follow that, I don't see any reasons why we all can come out in flying colors from this pandemic. So I think I've come to the end of my presentation and will like to answer if you have any questions.
The most common concern of us family physician is there's a lot of talk that patients above 40 or those with comorbidities, if already not on aspirin, should be started on aspirin when they are diagnosed with COVID and being treated. Please give your inputs on this.
Yeah, so aspirin is actually an antiplatelet. So I will not advise an aspirin to be taken after 40 age. That's a misconception. I feel the platelets are not affected by this thing. The clotting mechanism gets affected, which is anticoagulations. That too also, I will advise anticoagulation to patients whom the disease is very severe. For example, if your CRP levels are high, if your CT scan showing a lung involvement, if your other parameters like ferritin, D dimer is elevated, your LDH is elevated, that is the time when we start anticoagulation. So we have seen patients being treated with high doses of aspirin coming with gastritis, GI bleed, because as you already know, there's a whole lot of chunk of medicines which is prescribed to patients of COVID: hydroxychloroquine, ivermectin, doxycycline. So many medicines are given to patients of COVID. So I feel if the patient is a 40-year-old male who is active, whose infection is not much, who does not have an associated comorbidities like diabetes, hypertension, or dyslipidemia, I advise that let the patient be active at home. Make sure the patient's parameters like CRP, D dimer, ferritins are well done in advance and to be monitored. And if these things are well into control, I don't see any reasons to start on please remember, ecosprin is actually the trade name of ecosprin. The original chemical name of ecosprin is acetyl salicylic acid. It's an acid, so it's going to cause a lot of gastritis. So giving a long-term aspirin to people who have mild symptoms, I don't think so. But yes, if there's a 40-year-old man with a diabetes or other coronary artery disease factors, I will definitely give an aspirin to them.
Okay. Which anticoagulants to start? How long to use if
Okay,
we are
so
treating patient at home?
important is, do we need anticoagulation in all the patients? Of course, no. If you, as I said, as you said, a 40-year-old man who's active at home, I don't think he needs an anticoagulation. But yes, if a patient is a 65-year-old Maji or 75-year-old lady whom you feel that the patient is going to stay at home, does not going to mobilize, does not going to walk around, and physical activity will be restricted, and you find that patient is not mild, it's just more than mild, even though the saturation is normal, the CT scan showing some involvement, CRP being high, D dimer being elevated. Most importantly, the reason why we start anticoagulation is the D dimer. So if the D dimer is more than zero point 0.5, that's the time we start anticoagulation. Now anticoagulation depends upon where you are you getting admitted in the hospital, are you getting admitted at home? Now, nowadays, with the recent advances, the anticoagulation we start now is a NOAC, is a novel oral anticoagulations. These are like rivaroxaban, apixaban. Now, what is the advantage of these anticoagulation? The best advantage of these anticoagulation is you don't have to monitor INR, you don't have to monitor APTT or INR. So the doses are fixed. You don't have to think about if this patient takes a green vegetable along with warfarin, the values of INR will change. So these medications like Xarelto and Apixaban, they don't have an interactions with food items. They don't have interactions. Most of the time, they don't have interaction with other cardiac medications. So Xarelto or we is a trade name. There are other Indian molecules also, for example, Rivaflo, Rivaban, Ricosprin. These all are low costly rivaroxaban, which are easily available. The best part of that, you don't need to monitor. In a COVID situation like this, you cannot call people from lab to come and collect blood from you, or you cannot visit pathology lab all the time and give samples. So in that condition, these blood thinners are good because they don't need monitoring. So what I'll advise, usually if the renal functions are normal, I usually advise 20 milligram once daily of rivaroxaban for a month in a patient whose D dimer is high, whose CRP is high, who is sick, who is bedridden. That is how it is. Second thing, number two, if the patient's creatinine is borderline like 1.5, or if the patient is using an antiplatelet, already patient is on ecosprin or clopidogrel, I reduce the dose to 15 milligram once daily with food. What is important with rivaroxaban or Xarelto or Rivaflo or Ricosprin is that the medicine has to be taken once daily along with the food. So that is very important to keep in mind, that these drugs are the most preferred, and we and Fortis Hospital are using rivaroxaban or apixaban in most of these patients. And the duration we usually give for a patient who's getting discharged from ICU, who's getting discharged after a few days of ICU stays, is 1 month. 1 month is the time where we give this NOAC, novel oral anticoagulations. So oral anticoagulation, we all know they are warfarin and acetrom. Using a novel oral anticoagulation is rivaroxaban or apixaban. Of course, the patient, if is in ICU or IPD, some people do prefer injections. For example, low molecular weight Lexane and enoxaparin all once daily or twice daily based on D dimer level. But once the patient is discharged, 1 month of novel oral anticoagulation.
So it's a very good question. When at what level of D dimer should be taken as indicator for anticoagulation? Wouldn't
As I said,
resolving wouldn't resolving GGOs also elevate D dimer? So how do we interpret this biomarker?
no, I couldn't hear, sir. Can you repeat the question?
Would resolving GGO
Huh.
also raise D dimer
Hmm.
or not?
Yeah, see, if D dimer is elevated, different labs have different, different labs have different
Normal values.
values, but still normal. The D dimer is elevated,
I think his internet went off. We'll wait for him to join us back. There's one question on what cancers are common with obesity. You can have virtually all cancers common with obesity, including breast cancer, stomach cancer, prostate cancer. So we can't differentiate. Most cancers are related to tobacco, including bladder cancer, and most cancers are common in obesity.
Yeah, can you hear me, sir?
Yes, sir. Now we can hear you.
Yeah,
So you were
so
saying different labs have different normal values.
yeah, some people say zero point 0.9, some people say 900, some people say 500. So 500 nanogram is what we consider as a normal values. So if the patient has got more than 500 or usually double than this, double than the normal values, it's what we take it as a very significant. So in that, these patients plus patients, as I repeatedly said, the anticoagulations are double-edged sword. They are double-edged sword. If you use it improperly, you will end up in complications. If a patient is a fragile patient, his creatinine is on the higher side, and if you use a dose which is improper for that patient, the patient can come to you with a GI bleed. I have been seeing a lot of patients with GI bleeding, IC bleed, and rectus hematoma. A lot of patients with intra-abdominal rectus hematoma has been seen by me because of improper use. Please make sure you select your patients rightly. Make sure you give a proper dosing of that. That is why it is important that this NOAX works well in that, because you don't have to monitor the INR in these patients. Make sure that you, if you give a prophylactic dose rather than treatment of DVT or pulmonary embolism. A 15 milligram BD doses of Xarelto or a rivaroxaban can be harmful. So it is important that your dose selection is important. And as I said, if the patient has come out of ICU, if the patient has come with a lot of CT score, very high CT score, it's a time that these patients should receive anticoagulation for a month.
Okay. Dr. Brajesh, can somebody exercises, jogging, brisk walk be started immediately after recovering from COVID?
So, as I said, it depends upon how severe you have come out of it. If you have just discharged from a massive ICU involvement, please make sure the activity has to be gradual. But if your infection is mild, make sure you don't stop your activity. But brisk walk may not be advised, but make sure you are very active. You do some form of yoga, you do some form of static jogging, make sure you walk around at your home. Don't lie down on the bed for long. But if you are coming out of a massive ICU admission, 7 days, 10 days, 2 days of ventilator, 2 days of NIV, BiPAP, all those things, please make sure that the things are more gradual. Why? Because when you see a patient of COVID getting discharged, most of the time their heart rate will be very high. They will be tachycardic. The heart rate may be 100, 120. Doing an aggressive exercise right from the day one may not be good for him, as it puts an extra effort to the heart. So let it be gradual. Starts with a moderate speed walking, then slowly and slowly you pick up your speed and do that. Anything in excess of moderation will become a problem. So I'll not advise you anyway. After COVID, we advise 15 days of isolation. So you'll not be running around outside your home. Make sure whatever exercises possible at home to be done. Make sure you are active at home.
So there's a lot of talk going on of COVID vaccination causing clotting.
I don't believe that.
We also have been telling our patients, so I wanted a affirmation from your side.
Yeah, I don't believe that. See, I'm working in a COVID in a Fortis Hospital where we were actively involved in COVID infections and vaccination. A lot of vaccines were going on. I yet to see a patient coming to me with the clotting abnormalities. Second thing is, see, we forget very often that even before the COVID vaccine came, or even before the COVID infection came, we still used to have a lot of patients with clotting problems. We still used to have a lot of problems with cardiac patients. In fact, the maximum number of ER admission in my hospital used to be a cardiac admissions. So one patient gets an MI, we attribute everything to COVID, and we attribute everything to the COVID vaccine. So I totally deny that. I think as a doctors, we all are have a responsibility to make sure we relay these fears out of the mind from our patients. We make sure we tell them that I myself has taken vaccine 2 doses, nothing happened to me. I am a very pro to vaccine. I promote vaccine like anything. In fact, all my patients do ask me, I'm on a blood thinner, should I take it? Should I take this vaccine or not take this vaccine? I always advise them that vaccine is very, very safe. It has nothing to do with the cardiac medications. Of course, if somebody having a very high dose of anticoagulation, I do tell them that you stop 1 day of anticoagulation prior to the vaccine. And if the INR levels are very high, I make sure the vaccine is taken after the INR level is less than 2.5.
Sir, how do we treat arrhythmias in practice?
So
Leave
it depends.
aside ventricular, the atrial and other ones.
So the atrial arrhythmias depends upon is it reversible or irreversible. Suppose you come with the first time atrial fibrillation and you don't have a structural heart disease and it's an acute AF. So the aim of this treatment of acute AF is number one, to revert it into sinus rhythm. So what drug most of us is already available in our nursing home and clinic is the cordron. Other than that, we have drugs like ibutylide and all, which can be given IV, but I don't think it is available. So you in a small nursing home setting, you can cardivert with a cordron. You can give 150 milligram or 300 milligram over 30 minutes slowly, and then you can give an infusion. Make sure when you try to cardivert these patients, you should know that the AF is new onset. AF is less than within 24 hours. If you try to cardivert a patient who's there, who's having AF for long, it is possible that during cardioversion you can instigate an embolization, cardioembolization, and patient can have stroke. So in that condition, what we do a transesophageal echocardiogram. We look into the LA. If LA has got a clot, we don't cardiovert. If LA left atrial appendage or LA left atrium does not have a clot, we usually cardiovert these patients. So it is important to understand atrial fibrillation. Is it a lone atrial fibrillation? That means it is not associated with other structural abnormalities. Is the atrial fibrillation is new onset or is there for some time? Is the atrial fibrillation is associated with LA or LA appendage clot? That is one thing. That is the treatment of trying to cardiovert this. But sometimes when the AF is accepted AF, somebody comes to you with the AF being there for last 6 months. In that patients, the aim of the atrial fibrillation treatment is the rate control. So we try to control the rate. The drugs which we use is, of course, the diltiazem. We use a beta blockers. So we use a digoxin also sometimes used to control the rate, and along with that we give an anticoagulation. So anticoagulation, depending upon your choice or the patient's choice, can be a pixaban, rivaroxaban, warfarin, and acetrom, based on that.
Sir, how long to continue anticoagulation once you started, say D dimer was more than double?
one
So
month 1 month is
1 month.
usually what we recommend. One
उसके
month of
बाद do we check D dimer again?
I don't recommend that. The patient becomes active. I don't think we need to check D dimers again and again. Please make sure that this 1 month patient recovers and become active.
Okay. Treatment of myocarditis, anything you'll suggest at our end? Or what
So
you generally give?
so myocarditis treatment is usually a treatment of a heart failure. So if the patient is in heart failure, make sure you give some diuretics. See, steroids are not indicated for strict myocarditis. We do use steroid for COVID infection, but for myocarditis, if you see, the steroids are not indicated for myocarditis. So treatment of myocarditis is to tackle the storm. Just tackle the storm. If the patient has gotten myocarditis associated arrhythmias, give antiarrhythmic drug. If the patient has got a heart failure associated with myocarditis, please treat the heart failure along with that. Make sure you control the heart rate. If the patient has got a sinus bradycardia, if the heart rate being less, you can use drugs like ivabradine. You can use PFOX inhibitors like flavidon MR, that is trimetazidine. It basically acts by, it's a metabolic modulator of the heart, so it can help in that. Then certain new drugs are available like, Arni, Sidmas, Vimada. These drugs can be used in treatment of heart failure. So what is important is you need to bring back the patient to his original ejection fraction. So that has to be there. The treatment has to be there for some time. You need to use all your armaments to tackle heart failure related issues. So I have seen patients recovering completely if you are rightly treating them.
Does COVID present with hypertensive urgency?
Actually, as such, it can happen, but usually the hypertensive emergencies are usually because of acute arterial occlusion, patient having severe chest pain because of that, aortic dissection, or coarctation of aorta associated, or the patient being very anxious, panic. You can see a patient's not sleeping for 3 days coming to you in a ER with 150, 190 blood pressure, and just small sedation, some alprazolam or Restel at the night. Next day morning, you see the BP getting controlled. So it happens, but acute hypertensive urgency in a patient who has never been hypertension diagnosed, whose ECG is not showing features of hypertension, whose echo is not showing features of hypertension, make sure you rule out acute occlusion somewhere, make sure you rule out stroke somewhere, make sure you rule out some thrombus formation somewhere. I have seen patients presenting only with hypertensive emergency with some mild hypertension, headache and giddiness, finding out there's a stroke associated. So that was the reason. So it is important that other things, other scenarios has to be ruled out.
Are patients on ACE inhibitors or statins less prone to get COVID?
I don't think so. There is any relationship with ACE inhibitor. In fact, when the COVID started, there was a issue whether we should use ACE inhibitor or not in a COVID patient, because the most common side effect of ACE inhibitor is a dry cough. If you see all cardace, enalapril, ramipril, they causes a lot of dry cough. So I, as a policy, last 1.5 years, I've stopped using ACE inhibitors in patients of COVID. The reason being, you they see, if you cough in presence of 100 patients, everyone will run away from you, thinking that you have a COVID. So I usually avoid drugs which can induce, dilemma that this guy has can be a patient, potential COVID patient. So I don't give. Other than that, I can replace. You can easily replace with ARBs like telmisartan, losartan in place of ACE inhibitors. In fact, nowadays we have ARNIs which can replace ACE inhibitors like Vimada, Sidmas, and all those drugs can be used. So of course, statins are always good. Statins have a pleiotropic effect, but I don't know any research has been done that patients on statins are protected from COVID. I don't think there is any protection. In fact, it's really funny that we recently started seeing that patients who take a lot of steam, people used to say steam taking is a good for COVID, and realize
Getting
that
more
steam
COVID.
more prone because the
Yeah.
damages your mucosa. So that is one
I
thing.
have
So
been
I
also telling people not to take steam, not to take kada, nothing.
Yeah, so that is how it is. So I feel it's an infection, it's a viral infection, and I don't think anything can protect you. See, even the best of best people in the health can have COVID. So I have gone through the COVID. I am a football player. I played for Junior India. I also got COVID. My whole family got COVID. So I mean, universal precautions. Make sure you wear a mask. I think the most important preventive factor, which is of course a mask. Nothing more than that. So if you can afford a mask, you can. If you can afford a statins for long, you can afford a mask, face mask.
Atrial fibrillation with tachycardia, role of cardiovas.
See, any beta blockers can reduce the heart rate. So for in patients of atrial fibrillation with fast ventricular rate, you can reduce the heart rate by multiple ways. Number one is through beta blockers. Cardiovas is a beta blocker. It's a both alpha and beta blocker, so cardiovas can be given. Other beta blockers like metoprolol, bisoprolol, nebivolol, all will do the same work. Then there are other drugs like diltiazem, calcium channel blockers. They can also do the same work. Some people even use a codron. So codron can also reduce the heart rate. Digoxin is one of the drugs which can also reduce heart rate in atrial fibrillation patient. So in fact, the only indication nowadays to use digoxin is atrial fibrillation with fast ventricular rate with a patient with low ejection fraction. Somebody who comes to you with 15%, 20% AF with fast ventricular rate, you cannot give beta blockers because their BP is already on the lower side. You cannot give calcium channel blockers because the EF is less. So the only option which is left, of course, is digoxin.
Post-COVID atrial fibrillation, should we continue the same dose of NOAC?
Of course, yes, because in that patients, the aim is to prevent stroke related to atrial fibrillation. So if you see, almost 60 to 70% of the stroke, the underlying rhythm is atrial fibrillation. So in that case, please make sure that you continue the NOAC in all the patients of atrial fibrillation. If you can cardiovert the atrial fibrillation, if you can achieve a sinus rhythm, of course, in that case, you need to think whether we can stop the anticoagulation. But yes, need to continue.
Post-COVID tachycardia, generally in how many months it becomes normal, if at all, without medication?
Yeah, usually I have seen 6 weeks is a good time that it recovers. 6 weeks is the time when most of the inflammation or heart related issues, is getting settled. So 6 weeks is the time. So you can reassess your patients after 6 weeks.
This is non-related to COVID. If HDL is very low, 37, but LDL, TG are normal, should the patient be started on statins?
See, it depends upon what is the scenario. Nowadays, the LDL is not based on your what lab you get it done. It's based on individualized. For example, if you are a diabetic patient with smoking and this, my LDL level for you is less than 70. If you are a post angioplasty patient, my LDL for you is less than 55. If you are recurrent episode within 1 or 2 years, second episode of MI, the Lipid Association of India wants your LDL to be less than 30. So LDL is a dynamic number. It is individualized based on whom you are dealing with. Of course, for me, the treatment of HDL, low HDL, if the other parameters are normal, is not statins. For me, the best way to treat HDL is, of course, exercise, and sometimes it has shown that the almonds and walnuts also do increase the LDL. So HDL. So make sure you tell the patient to be active, exercise well, try to reduce other factors like obesity that can be given. There is a statin, especially statins which is known as pitvastatin. Pitvastatin has shown that it can increase the HDL. And if you ask me about these three statins like atorvastatin, rosuvastatin, pitvastatin, I feel the atorvastatin is the one which reduces HDL more. So since suppose you are following a patient for last 10 years with a lipid profile reports every 3 months or 6 months, you find that if the patient is on atorvastatin, his LDL may be falling every time he comes to you, but his HDL may also be falling. So in that scenario, the rosuvastatin scores more over atorvastatin, that it increases HDL or may not disturb HDL. And pitvastatin being another statins which has shown that it does not affect the HDL much. Second thing is that it does not cause too much of myopathy. So it comes as a Pvasta, 4 milligram. You can use it, and I mean for a patient who needs a moderate intensity statins, pitvastatin is one of the drug which does not affect HDL much.
Sir, in CHF, ARNA is better with furosemide or spironolactone?
So, see, Arni and furosemide and spironolactone are three different drugs. See, if you see what is spironolactone, spironolactone is shown mortality benefit. The furosemide is for symptoms control. There are certain drugs in heart failure which have shown mortality benefit. For example, beta blockers, then mineralocorticoid receptor antagonist like spironolactone, ACE inhibitor ARBs, and then ARNI. So ARNI, this question actually should not be asked because they are different compounds. ARNI and spironolactone are a very good combination. They should be given to a patient, and furosemide to be added based on symptoms. If you ask me, Lasix or Ditor, they have no effect on mortality. They improve the patient's symptoms, but spironolactone, ARNI, beta blockers, they have a mortality benefit. So most of the drugs, if you see like Ditor 10 plus, Lacilactone, they are basically combination of Lasix, that is furosemide, with aldactone, that is spironolactone. So they are combination of these drugs. So there is no question of differentiating between them. Arni should be used along with the spironolactone, and Lasix or furosemide to be added based on the symptoms. If the patient has got an heart failure symptoms more, cannot be treated with a spironolactone alone, please make sure you add some doses of Lasix or furosemide.
Post-COVID tachycardia, beta blocker versus ivabradine.
Yeah, so it depends upon what is the blood pressure. If the patient blood pressure is on the lower side, if the patient is coming with 100 blood pressure, and if you use a beta blocker, you end up in having BP falling. Most of the patients of COVID will have a lot of lethargy, weakness. So if you give a beta blockers to them, then these patients will have more tiredness. So ivabradine is preferred in that. But in another scenario, where the patient is coming to you with a 160 by 90 blood pressure and the heart rate being 110 or 120, You change your antihypertensive to a beta blocker, you make it bisoprolol, nebivolol, or carvedilol, or metoprolol, you end up in tackling the issues better. You can treat BP with one medicine rather than you giving telmisartan, amlodipine along with the ivabradine. So in that scenario, a single beta blocker can work as an antihypertensive, can also work to reduce the heart rate. So the ivabradine scores over beta blocker when the BP is borderline, where you cannot afford to give beta blockers. Ivabradine scores in that.
69-year-old female, known case of pulmonary hypertension OSA, now off CPAP, pulmonary hypertension normal, antihypertensive is mild, ST changes on ECG. Should we do angiogram? BP is under control, no symptoms.
No, it depends upon what type of STT changes in that. And number two, please make sure the patient is, don't put him out of BiPAP, because OSA, you cannot
Get
remove
rid of
BiPAP.
OSA.
Yeah, get rid of OSA. OSA is going to come. See, even a surgical treatment of OSA, most of the time it fails. So patient needs a BiPAP or this thing CPAP. That is must. There is no doubt about it. Regarding STT changes, I need to see what type of changes. Is the blood pressure changes? Can the patient can do a treadmill test? If the patient can do treadmill test, then go for a treadmill test. What is the echo finding? Is there any other reason for STT changes? Sometimes an RBBB, LBBB can have an STT changes. Usually, advising a patient based on a minor ECG changes, an angiogram creates more confusion. For example, somebody comes with a minor STT changes and you did an angiogram and you found that 70% or 60% blocked. Then will you do an angioplasty? So whenever we do something, you should be ready to see what next you will be able to do it, whether you will be able to do next, what you will be able to do next. So similar patient, if the patient is a diabetic, hypertensive, smoker patient, comes to me with a breathlessness unexplained by OSA, I will definitely do an angiogram. But a patient does not have a diabetic, hypertension, non-smoker, simple OSA, no other risk factors, with some mild STT changes, I may not advise. I may do a treadmill test if possible. I will look for the echo. So that is possible. And the best delabeling technique, if you wanted to delabel a patient, of course, a CT angiogram, which is probably a non-invasive and it's easily acceptable by population, can be advised. The 64 slice CT scan or 124 slice CT coronary angiogram can be done in these patients. Of course.
Is cardiomyopathy reversible in post-COVID?
I have seen that. I have seen patients getting reversed. I have seen patients with 15%, 20% patients after probably 6 weeks or 6 months, they are going back with 55, 60% patients. It definitely, it is reversible. But if you ask me what percentage, difficult to answer. Yes, 25 to 30% patients, I have seen people reversing. I have seen that. I recently put an AICD to one of the patient post-COVID. His EF was 15%. I put an CRTD AICD combination. That's a combo device. Patient is doing very well. Now the EF is around 40-45%. I'm expecting that this patient will come back to me after a few months with much more better EF. So let us see.
Any pointers to different which one to use, epaxiban or rivaroxaban?
So it depends upon your choice. Say I'll give you some examples. Apixaban is used twice daily. Rivaroxaban is given once daily. So that is always an advantage. Plus, there's a very clear-cut defined, renal doses of rivaroxaban. I, being a fan of rivaroxaban, I give, for example, patient is not on dialysis, is GFR is more than 30%, rivaroxaban 15 milligram is good enough. Rivaroxaban has got a very clear-cut dosing along with the antiplatelet. For example, if you're using a single antiplatelet, icosapent and clopidogrel, and you need to use a rivaroxaban, you need to give 15 milligram once daily. So of course there are advantages and of course personal choices as well. But I feel rivaroxaban for me scores over others in terms of, most importantly for me is the compliance of the patient. If the patient compliance is poor, no drug is going to work. So make sure that compliance is important, and then the rivaroxaban scores over it. And I have been using rivaroxaban for last, I think, 6 to 7 years, both in pulmonary embolism, DVTs and all, and I've been getting very good result.
Sir, two last questions. Patient complained of pain and heaviness of calf muscles but no external changes. What does it signify? History of angioplasty in past.
So this can show, this can be a feature of peripheral arterial disease, peripheral vascular disease. Now, if the patient says that he has a calf pain on walking, On walking, he has a calf pain and patient has to sit and take rest. This is a classical sign of claudication.
Claudication.
So make sure that you can, to start with, you can do a Doppler, you can do an arterial Doppler to look for what is happening. But arterial Dopplers sometimes, they are very subjective. It depends upon which radiologist is doing it, how much experience he is. CT peripheral angiogram is one of the choice which can tell you exactly what is happening in the limb. So CT peripheral angiogram is one of the good choices.
Why LVH is more prone to cause electrical malfunction, that is arrhythmias?
Yeah, see, to be very frank, I'm not sure whether it's an LVH or see, we do see a patient's ECG suggesting of LVH. Sometimes when we investigate these patients, we do a cardiac MRI, we found that these patients have hypertrophic cardiomyopathy. Because hypertrophic cardiomyopathy, HOCM, sometimes their ECG is very similar to LVH. So the hypertrophic cardiomyopathy may be an underlying disease which is causing arrhythmia problem or electrolyte abnormalities. But of course, the LVH, the muscle mass is more. The muscle mass can have a scarring, can have a fibrosis, that can lead to this. But whenever you see an LVH in the ECG or echo, I think just think about, are you missing HCM, hypertrophic cardiomyopathy? Because that is one of the reasons patients can have sudden death arrhythmias.
Rivaroxaban 10 mg also is given.
Yes, 10 mg is a dose which most of our orthopedic friends are giving it for post knee replacement prophylaxis, post hip replacement prophylaxis. So 10 milligram. Of course, nowadays we are using even 2.5 milligram BD for coronary artery disease patient, but 10 milligram is of course used for prophylaxis.
Okay, Dr. Brajesh, you have been just wonderful.
Thank you, sir.
I have been getting feedback from my participants. I'll send you the chat. And I had requested, he is very humble. I had requested him to share his contact details. He is not showing. So I am going to show you. He is a consultant at Vashi Hospital Fortis, and this is his private clinic, Sector 46, Seawood, Navi Mumbai. Any one of you wants his phone number has to connect to me or Preeti. Then we will give. I will not share on a public domain. So, Dr. Brajesh, once again, thank you very much.
Yeah, thank
And
you, sir.
I would like to ask your permission. Can this video go on YouTube for free viewing by people in future?
Absolutely, sir. Something which is helping people to understand COVID and cardiology. I mean, it's most welcome.
Like we have had, like you are about the 9th or 10th expert on this forum. We had about 56 webinars, but you have been outstanding. Like you have cleared so many doubts and given us so much knowledge that I can't thank you. Thank you very much.
Thank you, sir. Thank you. Thank you. Thank you, sir.
Yeah. So I will keep this slide on for some time.